name is Noelle Marie Javier, and my pronouns are she, her, hers. It is such an honor to be part of this very prestigious and esteemed convention for the Philippine Academy of Family Physicians, 60th Annual Convention. I am an associate professor of medicine with the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai in New York City, New York. And the topic that I will be covering for today's session is culturally sensitive, competent, inclusive, and affirmative approach to geriatric and palliative care for the older LGBTQ adult in the era of COVID-19. The vision that we want as providers when it comes to the care of our older and seriously ill LGBTQ adults, also known as sexual and gender minorities, is to have a vision where the care is culturally holistic, competent, sensitive, humble, affirmative, inclusive, and compassionate healthcare approach. I do not have any financial disclosures. And over this session, we would like to cover these three main areas, especially demographics, guiding principles, and affirmative strategies. I was able to lift this data looking at a survey that was done on 700 respondents for the time period of December 2015 to January of 2016. And this was an online survey asking a specific question whether the respondent knows of someone personally who identifies as gay, lesbian, or bisexual, and or is attracted to people of the same sex. And it is clearly pointed in this data that 61% of the respondents identified someone whom they know personally who is attracted to people of the same sex or who identify as gay, lesbian, or bisexual. Unfortunately, the transgender population and the gender non-binary group were not included in this data set. And another statistic, it was found out that about 12 million Filipinos identify as LGBT, and this is with relation to the 109 Filipinos roughly as an estimated population for the year 2020. Of the same survey, only about 25% of the respondents supported same-sex marriage, which really speaks to the status of the Philippines, which is really my beloved country, even though I'm residing in the States now, that there's still a long ways to go when it comes to acceptance and not just tolerance, but really full acceptance of the LGBTQ population. Now, given that sexual and gender minorities, also known as LGBTQ, is considered a minority population and really a marginalized population at that, it is even more striking that in the era of COVID-19, there is more marginalization and or perhaps discrimination towards the LGBTQ population. I was able to look this data up for the COVID-19 statistics, and as you can see, during last year's period from May to November, that the Philippines as a country was not really spared from the coronavirus pandemic, unfortunately. And we can see the rising cases within the months of July through August and a nadir after that. Nonetheless, this does not include data that has not been reported and or properly documented in these statistics. So there is definitely a call to action amongst all providers, including all of you, members of the Philippine Academy of Family Physicians and allied healthcare personnel. The American Medical Association of which I am a member of as well, really looked into the patient-physician relationship as something that is viewed as an exercise as expensive, which means that there is an utmost respect for law and human rights. Physicians and other healthcare providers may not decline to accept patients because of their identities, whether it's race, color, religion, national origin, sexual orientation, gender identity, or any other basis that would constitute invidious discrimination. I would also uphold that the Philippine Medical Association would do the same thing as well. It is important to note that while as you're viewing this session, you don't have to be LGBTQ to do this well, to provide appropriate and inclusive medical care. And furthermore, just because a person belongs to the LGBTQ population, they obviously also do not make themselves, in and of themselves, experts in their own medical care. So this really begs the question of allowing a partnership between patient and physician. I think that for the clinicians, there's definitely a growing need to learn about LGBTQ health and the range of lived experiences, particularly around the issues of sexual orientation and gender identity. For the non-clinical staff, and this includes your front desk, patient registration staff, and other staff, they must also be versed at LGBTQ health training, being able to communicate properly with the LGBTQ patients, and being able to work with the clinical providers to achieve the highest possible quality of care with diverse patient populations. And as far as the patients are concerned, there is a need to learn about why it is important to communicate this information and feel comfortable that it will be used appropriately. And why I said this information is that there is a need to really bring people out of the closet, if you would, and really provide them with visibility and open visibility so that they can exist and cohabitate with other members of the mainstream population. So SOGI stands for sexual orientation, gender identity, and gender expression. And let's define that a little bit more. And I have included an illustration, a couple of illustrations, really signifying the difference between these three constructs. First of all, sexual orientation refers to a person's attraction, whether it's sexual and or emotional. It also refers to the person's practice, sexual behavior. And again, it could be through one particular gender or sex and ranging into encompassing multiple genders and sex. On the other hand, gender identity really refers to a person's internal sense of being themselves, whether they identify as male or female, somewhere in the middle, or another gender. So I'd like to think of gender identity as the person's self-image or self-perception. Gender expression, on the other hand, is another construct that we will be discussing a little bit further as we move along with the slides. So one would think as, and in simple terms, one could say that gender identity and sexual orientation are distinct concepts. They're not, but they're also not mutually exclusive. And so in the right diagram, you can see that there is an overlap or intersection amongst these three constructs. Now, speaking of gender identity, another helpful tip to differentiate sexual orientation and gender identity is that one could say that gender identity is the person that they go to bed as, and the sexual orientation is the concept where the individual goes to bed with, a person that identifies of the same gender or a different gender. So transgender, for instance, means that there is a mismatching or misalignment of the person's sex or gender at birth, which is the natal sex, and also the person's gender identity, how they identify as. So I am a perfect example of a woman who identifies as transgender because even though I was assigned male at birth based on biological characteristics, I do not in any way identify as male, and I am 100% woman and identify myself as female with respect to my mind, my heart, my soul, my actions, my personality, and everything else. So when there is misalignment of the natal sex and gender identity, that's what you call transgender. And when there is alignment or concordance between gender identity and sexual orientation, alignment of natal sex and anatomy and gender identity, then that is what you call cisgender, or what we also refer to as biological male or female. Gender expression denotes the external manifestation of the characteristics in one's personality, appearance, and behavior that are culturally defined as masculine or feminine, something else, or somewhere in the middle. So, for instance, with Caitlyn Jenner, as you all know, she's also a transgender woman who was assigned male at birth and transitioned later in life to be the woman that she is. You can also look at some of these other pictures, and you cannot necessarily say for sure that a person, let's say on the the middle upper left corner, may look androgynous, and this person may identify as either male or female or non-binary. On the other hand, the couple on the right hand side is actually a real life picture, and all of these are real life pictures. But this couple have become quite the celebrity because both of them are transgender. She's a transgender female and he's a transgender male, and they are in a relationship. So why do we even bother taking a stance at LGBTQ healthcare? Because there is, in fact, continued and perpetual indisability. People are really not asking the questions. Have you ever thought about being asked by your provider whether you identify as a certain gender or what your sexual orientation is, whether you are straight or heterosexual, gay, lesbian, bisexual, pansexual? Has anybody really asked you about that? And if not, it's high time that we do so, because it is part of holistic care. So over the next few slides, I'd like to cover some important data points that I think have really championed collection of SOGI data. This was featured in the New York Times. It was entitled "Gay and Transgender Patients to Doctors Will Tell, Just Ask." And this was an article that was published in 2017. And out of this article, it highlighted two studies. One is the equality study of 2017, which was really an exploratory sequential mixed method design that used online surveys and focus group qualitative interviews in the greater Baltimore area, including the capital of the United States, which is Washington, D.C. They looked at patients and health professionals alike, and they have asked them to complete an in-focus survey and also an online survey. And their outcomes was really to quantitate data on sexual orientation and the willingness of the patients to disclose that. So the mean age of the patient and the provider are really not significantly different within the middle age group. What they found was that patients are less likely to refuse SOGI disclosure, meaning that if you ask a person whether or not you know the person is LGBT or non-LGBT, that the person is more than likely to disclose SOGI if they are appropriately asked. And in fact, only 10% of patients reported refusal for SOGI information. They didn't really go into the details as to why these individuals reported refusal. What is even more striking is that more than 2/3 of the providers thought that the patients would refuse SOGI information. So in a way, this gives the providers an onus to skip this information because of a variety of reasons, whether they don't think that it is relevant to the medical history, or they in and of themselves are uncomfortable asking these questions that might be deemed sensitive and intrusive to patients. So the clinical bottom line is that we need to implement a standardized patient-centered approach for routine collection of SOGI data. If we don't have it in your medical records or your handwritten records, if you don't ask, people don't tell. And if people don't tell, then you're missing out on the big piece of the puzzle, which is to try to provide holistic, compassionate care. In a parallel study, they asked specifically about transgender patients, and they also collected SOGI data. And in their results, it was found out that males were roughly just a bit more predominant than the females who identified in the respondents. A lot of them, more than 2/3 again of them, felt that gender identity was more important to disclose to primary care providers than sexual orientation. And it was across the board that females, both females and males alike, are reporting the relevance of gender identity, especially as it relates to the chief complaint. So for as long as there is an LGBTQ-friendly environment, patients will be comfortable in disclosing their SOGI information. Furthermore, it was also reported that patients are more than happy to educate providers in healthcare. So the bottom line here is that there is, in fact, equal billing of both gender identity and sexual orientations if people just ask. For transgender and gender non-binary individuals, gender identity is definitely important to disclose, especially if it relates to their care. Nonetheless, a lot of the respondents and people in general are willing to disclose SOGI. So this is an example. If you use electronic medical health records, then you can just include the question of sexual orientation and gender identity, just like in any other demographic data set, and normalize the situation, not make it really stand out. It's just like asking their name, where they live, their employment history, their relationship status, and you can also include a question. And a good example is, do you think of yourself as lesbian, gay, or homosexual, straight, bisexual, something else, don't know? So this is an important question for gender identity and sexual orientation. What is your current gender identity, right? And what is your sex assigned at birth? Because we know that those two are two distinctive realms in terms of gender identity, and we need to be very intentional about asking them. So I want to take a moment to review some guiding principles and core concepts in terms of the LGBTQ population. The minority stress model was illustrated by a social scientist by the name of Elon Meyer in 2003, who is a faculty at Columbia University, used to be a faculty at Columbia University, and now is in California. And what he indicated was that there is insurmountable oppression and marginalization of the LGBTQ population. And it starts with how these individuals are shaped and influenced by circumstances in the external environment, and how this relates to their own minority status, whether they're they're part of the LGBTQ community, and also looking at other identities that identify them as minority. So here, as you know, in the United States, we have a diverse population. People from all over the world live here. So it's not a homogeneous group. So definitely Asian people such as myself and people of Hispanic and or Black African-American identities are considered minorities here in the States. So if you already have external stressors that are influencing or affecting you a certain way, it is furthermore compounded by your own intrinsic stressors, how you deal and how you cope with external stressors that come about, such as outright prejudice and discrimination, and also even physical, verbal, emotional, and sexual abuse. And this leads further to significant mental health outcomes, whether it's negative or positive, right? Because a lot of the times, if people do not have adequate support networks, what ends up happening is there is a high prevalence of anxiety, depression, and other mental health issues. However, if there is also good support system, whether it's through community, religious affiliations, or their own biological families, or even families of choice, then individuals are able to thrive much more responsibly and also much more healthily in that sense. Because of minority stress, there are definite contributors to this and/or outcomes that are pertinent. For the purpose of this session, we're going to definitely talk about the healthcare disparities that affect this minority stress. Same-sex couples are twice as likely as their counterparts to be discriminated against, 5 times more likely to have experienced discrimination, and certainly will lead to significant mental health issues, including substance use disorder. So this long history of stigma, prejudice, and discrimination could not be overemphasized. One needs to really take the time and be intentional about understanding, having awareness, reviewing, and studying the long history of oppression. And we know for a fact that as our LGBTQ individuals age over time, they have now experienced and lived through times where there was insurmountable oppression, leading to significant aging stressors, which are contributed by greater risk and lead to greater risk for physical and mental illness, social isolation, family abandonment, mental health issues, poor nutrition, delays in seeking care, chronic illnesses and active comorbidities, premature deaths, also legal inequalities and lack of spirituality. So a few of the healthcare disparities I wanted to highlight specifically with the transgender population, because the transgender community is a minority within a minority. And as you can tell, as compared to the general data out of NIH, National Institutes of Health, being transgender is associated with just higher risk for HIV, incarceration, homelessness, substance use disorder, and suicide attempts. In fact, up to 41%, and maybe even as high as up to 65% of transgender and gender binary population have attempted suicide in their lifetime. So what about with COVID-19? So as we all know, COVID-19 further magnifies the marginalization of this already oppressed minority population. Why? Because with COVID-19, there's definitely increased isolation. The fact that we can't even see, patients can't see their loved ones, we're wearing PPEs, their patients are in isolation rooms. It is really an isolating and an oppressive disease. Furthermore, there are economic downsides to this, with higher unemployment leading to financial constraints, and that in and of themselves can delay individuals in seeking medical care because they have to pay the rent and they're living paycheck to paycheck and they have to provide food on the table. There's definitely lack of caregiving support. We already know that a lot of the LGBTQ population have been ostracized and shunned by their own biological families. So they end up being alone or they create their new families. There's also very high stress levels, as we all know. We know that women, as part of as part of the gender minority as well, experience a significant high level of stress, leading to hypertension, heart disease, anxiety, and depression. And if you're a woman, and if you're transgender or a lesbian, and if you're Asian and are a minority such as myself, just imagine I am a triple threat when it comes to marginalization living here in the US. And I also wanted to cover the concept of intersectionality, that when you are faced with an LGBTQ identified individual or patient, that person is not solely defined by their SOGI or their LGBTQ identity. That person is also defined by their class, their education, their language, their culture. So if you have a patient right before you who is part of the indigenous tribes, let's say of Pampanga, and this person is, may not necessarily be educated, may be of short stature, may have a different color. And if this person identifies of a certain gender, then that person will be at great risk for persecution, victimization, and isolation. So I think for us as providers, we need to understand that there is a confluence of different identities, and a lot of them can be identities that put them at further risk for vulnerability. So this is an example. So this particular patient is African American, and is disabled. She's older. She may not necessarily have the right education, or what we consider as higher education. She's a woman, and if she is lesbian, then she can be at risk for society's very heteronormative type of approach, which means that everyone is assumed heterosexual if they live in mainstream society. So as a provider, you want to offer holistic care, and when you say holistic care, you have to look at different dimensions, whether it's physical, mental, emotional, or psychological, sexual, cultural, religious, financial, and social. You have to look into all of these dimensions as part of holistic care for these individuals. Otherwise, your care will be lopsided and very unilateral. So what we want is an open-minded approach. Avoid making assumptions that a person is straight or that the person is cisgender or biologically male or female. You also have to avoid assuming that the patient's sexuality is constant. There's now this emerging concepts of gender fluidity, where people and sexual fluidity, whereby individuals identify as, let's say, straight when they were in their teenage years, and then going into college, they become more bisexual, and then later on they become gay. And so that is an absolute fact that happens, and we cannot close our eyes to that sexuality can be fluid. We try to avoid forcing labels, and calling out people and mislabeling them. Having lived in the Philippines for a long time, I've certainly been a victim of such oppressive and quite punitive labels that have really led to emotional frustration and grief. And in the same way that I am feeling this about myself and how I was perceived by society, it's really important that I advocate and I stand up for patients who identify a certain way and not subject them to unnecessary labels. Also, to be mindful of appropriate questions to ask, and even comments about transgender patients and assumptions that may not necessarily be appropriate, like assuming that all transgender patients are engaging in commercial sex work, or that transgender patients all want to have plastic surgeries to look a certain way. It's really patient dependent. We want to have an environment that is welcoming and visible. So you need to have visible indicators. You want to be able to provide cultural competency training to your staff so that they know how to appropriately address a person. You want to have some paraphernalia and some other resources that are exposed so that people, when they go to your clinic or to your hospital, that they feel welcome in this hospital or in this institution. These are just examples, right? The rainbow flag and the pink inverted pink triangle flag, and then the human rights equality flag are all symbols of LGBTQ friendliness and welcoming environment. Having outright Bill of Rights, having policies that say we don't discriminate based on your SOGI information is really helpful for a lot of our patients. So in summary, I think that we need to really understand the rich history of the LGBTQ population. We want to show openness, and we want to debunk negative attitudes. Whatever preconceived notions you have, we need to put them aside, deconstruct them, and start anew, and be at level with our patients, and also allowing them to teach us by way of humility. I think that we need to listen to the story of the patient, allow them to take the lead. We need to practice the dignity question. The dignity question is simply asking the individual, what is it about you that you want to disclose or they want to share with me that will allow me to provide you with the best care? This was a question that was coined or created by Harvey Max Chochinov in Canada as a palliative care doctor. And this is part of holistic care. We want to show visibility and inclusiveness. Cultural competency and training is really important. We want to take into account nuances in the medical care of the LGBTQ older adult patient. And we want to discuss advanced care planning and preferences for care. So I think it's really, really important. Back in the day, I know, having lived in the Philippines, that talking about advanced care planning was quite a taboo because people don't really want to talk about death and dying, what will happen if scenarios where you have an irreversible illness happens. People don't usually talk about that. But because of the championship of, Dr. K, Ignacio Estepa, Dr. Terry Laude, and the rest of the doctors who practice palliative care and hospice in the country, we have now championed and advocated for, including advanced care planning. This is really part of, and in fact, one of the bread and butter of palliative care is to provide holistic care. We need to be able to think out of the box and look at the what if circumstances that will happen to patients when they are seriously ill, so that the providers are well guided in terms of the next steps in their care. And we need to want to include a holistic approach, which means that we have to rely on other members of the team. It takes a village to change healthcare, and we cannot do it alone. So we have to rely on some of our other team members, whether they're nurses, whether there are chaplains or spiritual counselors, social workers. All of these individuals are very important. We don't see them as less than. They are partners in our care, and it's really, really important to have them included from the get-go. If there's anything that I'd like to end, I'd like to just end with a quote from Mother Teresa, who I consider my heroine and one of the greatest saints. And she said, if you judge people, you have no time to love them. So we need to leave our judgments aside, and we need to start loving people for who they are. Thank you so much for attending this session. I am more than happy to receive questions. And you can feel free to email me, with this email address.